name's Caroline. I'm one of the F1s at St James's, and I'm going to go through haematology and transfusions. So the aims and objectives is a whistle-stop tour of your syllabus. I'm going to be going quite fast so that I can cover everything in your syllabus. I've made handouts which will go on the website after this talk, so you don't feel the need to write. What I hope to show to you today is that a lot of haematology can seem a bit daunting, but actually you can work out a lot of it from first principles. And as we'll go through this talk, you'll see that the same themes keep coming up again and again. So if you can get to grips with them the first time, then you'll attract it. For each topic, I've highlighted in red a learning point. That's something I think you either really need to know, or something that the examiners just love asking them about. Okay, so let's start with the anemias. So we're going to look first of all at microcytic anemias. A microcytic anemia is basically due to either a defect in production of heme or of globin. So those are the two things that can cause a microcytic anemia. In terms of your heme, we've got iron deficiency, which is a big part of your syllabus, and then a slightly rarer sideroblastic anemia, which is basically due to a defect in the heme synthesis itself. And then globins, we've got thalassemias, and we'll look at those. So let's look at iron deficiency anemia. With any of your deficiencies, it's a really good idea if you can break it down and categorize it. So we can break the iron deficiency down into either a problem of intake, absorption, demand, or loss. So intake, a lot of iron comes from meat, so vegans, for example, the elderly who have a really poor diet, tea and toast diet. Absorption, you need hydrogen chloride from the stomach in order to digest your iron, and you then absorb it in the small intestine. So you can think of any kind of disease that affects these two parts of the digestive tract, and you've got a cause for iron deficiency. Demand, so if you're making a large number of red blood cells, you have a high iron demand, and that can outstrip your intake. And then loss, and this is our first learning point of the lecture, that iron deficiency anemia in an adult is an occult malignancy until proven otherwise. So blood loss, you lose those red blood cells, you lose the iron that they contain, it's not replenished, and consequently you get an iron deficiency picture. And particularly you're thinking GI malignancy and urogyne malignancy. Okay. So how does someone with an iron deficiency anemia present? Well, you've got the signs and symptoms of anemia. So can someone shout out a sign or a symptom of anemia?
Shortness of breath.
Shortness of breath, yeah.
Dizziness.
Dizziness, fatigue,
Pallor.
yeah, exactly. They're great. You might get chest pain if they've got narrowed coronary arteries already. Okay, so you've got your signs and symptoms of your anemia. You've got signs and symptoms of the cause. So if you remember what we went through, can you think of any signs or symptoms if you've got a GI problem? So there was some problem with your small intestine, what sort of signs or symptoms might you have? For example, Crohn's disease. Steatorrhea, yeah. Diarrhea. Weight loss, yeah. Yeah. So already you can see, you can rattle off, you can start thinking of these things when you're assessing a patient with iron deficiency anemia. So that's great. And then there's signs that are specific to iron deficiency itself. So who knows what koilonychia is? You all know what koilonychia is, that's great. Glossitis, which is smooth tongue, yeah, and angular stomatitis, which is dryness around the corners of your mouth. So those are the things that you can be looking for when you assess a patient. Okay, what you're going to find on the blood tests, well, it's a hypochromic microcytic picture, so the red blood cells are pale and small. You also get these very long words, megaloblastic and anisocytosis, which means you're going to get variable shaped red blood cells and variable sizes of your red blood cells when you look at that blood film. You'll be looking to see if your iron stores are low, so ferritin will be decreased, that's a sign of your body's iron stores, apart from, when might it not be decreased? What was that, sorry?
It's an acute phase reaction to viral infection.
Exactly, it's an acute phase protein, so a red herring, if they've got infection or inflammation or malignancy, they could still have an iron deficiency picture with a normal ferritin. And the iron binding capacity will be increased. So your body's able to bind a lot more iron because there's just not much iron around. And also, you're going to investigate the causes. You're going to be thinking about, as we said, small intestine. You could do some tests to look at what's going on there, and particularly looking at these malignancies. How would you investigate a potential GI malignancy? What was that?
Endoscopy.
Endoscopy, yeah, excellent.
Form test.
What?
Fecal or coats.
Yeah, you could do that as a screening. So yeah, and urine dip for urine malignancies. That's great. How are we going to treat the patient? Again, you can break it down. So you can treat the anemia per se if they're symptomatic and they've got a hemoglobin less than 8. You might consider a blood transfusion. You can treat the iron deficiency. You would give iron replacement in the form of oral iron. And then obviously looking at the cause, what's caused this underlying iron deficiency, because you really need to tackle that. So that was your microcytic anemia due to a problem with heme synthesis. So now we're going to look at microcytic anemia due to a problem with globin synthesis, so thalassaemias. So thalassaemias are autosomal recessive conditions, and it's due to mutations in the globin gene, so you get less globin production. And you've got alpha and beta thalassaemias. With your alpha, you've got 4 genes that control alpha globin. And basically, depending upon the number of genes that are knocked out and depending upon the amount of alpha globin you can produce, that will affect the severity of the anemia. So if you've knocked out all 4 of your alpha genes, you get a condition called hydrops fetalis, which is basically the fetus goes into heart failure and dies. And then so on and so forth, until really, if you've only got 1 or 2 mutations, you can actually have a very mild anemia. And similarly with your beta globin, that's controlled by 2 genes. Major is when you knock out both your genes, and very symptomatic. Symptoms begin at 3 to 6 months, because that's when the fetal hemoglobin converts to your adult hemoglobin. So that's when you're going to first notice the fact that your beta globin isn't around. Intermediate is just mild, and you can have the trait if you're just a heterozygous carrier. So again, they can be confusing terms to get your head around, but basically it's just saying how severe the thalassemia is, depending upon the number of mutations. Okay. And this is a learning point, that you get an anemia with your thalassemias. And in addition to that, because your bone marrow can't make the red blood cells, other sites around the body take up that role. So you get this called extramedullary hematopoiesis. Does anyone know how this can manifest? Which of the sites? Splenomegaly. You guys are really good. Yes, splenomegaly. Where else can you get extramedullary hematopoiesis? The skull. Yeah, what do you get on the skull? Bossing. Yeah, frontal bossing. What else do you get on the skull?
It's like hairs.
Hair on end on an X-ray appearance, yeah, that's great. Yeah, and in addition to this being, you can get hepatomegaly as well. So excellent. How are we going to investigate our thalassemias? We're going to do electrophoresis, looking at the levels of your globins. And how are we going to treat it? It depends how symptomatic they are and how severe it is. But blood transfusions and splenectomy. So if you take out the spleen, then it won't consume the red blood cells as much. Now I've put iron chelation. Why have I put that?
Because the iron builds up with each transfusion that they have.
Yeah, so patients who have thalassemia, they're going to be having multiple blood transfusions throughout their lifetime, and they'll get a build-up of iron. What's that condition called? Hemochromatosis, yeah. So we give iron chelation to try and prevent that. Okay, so that was a whirlwind tour of microcytic anemias. Is everyone happy? You guys seem to know it all already, so that's great. Okay, macrocytic anemias, the opposite end of the spectrum. You can divide them into megaloblastic and non-megaloblastic. So non-megaloblastic, here's some causes, and it's a good idea just to know some. So alcohol, low thyroid, hemolysis. Hemolysis is because if you break down your red blood cells, you get more of the younger red blood cells, which are larger. So that's why it's a macrocytic picture. Similarly with your myelodysplasia and in pregnancy. And then you've got your megaloblastic. So megaloblastic basically means things that affect the nucleus. So we're looking at B12 or folate deficiency. And again, it just goes back to the slide on iron deficiency. If you've got a deficiency, divide it up. So you can divide it again into intake, absorption, demand, and this last category is metabolism. So intake, B12 if you're a vegan, folate comes from foliage, leafy green vegetables, so if you don't eat many of those. Absorption, again, we're looking at the stomach and the small intestine. What specific condition in the stomach do you think of when I say B12 deficiency? Yeah, pernicious anemia, yeah, that's great. But it can be any condition that affects the stomach, so what else could you have that affects your stomach? Terminal ileostomy, gastrectomy, yeah. And what can affect your small intestine? We've sort of covered this already. Crohn's, yeah. What else? Celiac can affect your small intestine, yeah. If you've had some of it resected, if you've got bacterial overgrowth, lots and lots of causes. Demand is the same list that we saw in iron deficiency. And metabolism, just so you know that some drugs can interfere with your B12 folate metabolic pathways. For example, trimethoprim and methotrexate. Okay. So, really similar to the last slide. How do they present? Symptoms and signs of anemia, you guys have told me those already. Symptoms and signs associated with the cause, we've gone through that already. And then finally, symptoms and signs associated with B12 deficiency. So there's an overlap with your iron deficiency in terms of your stomatitis and your glossitis. Subacute combined degeneration of the spinal cord. Have you guys heard of this one? Yeah. Can anyone describe it? What happens there? Dorsal columns, and which other columns? Your lateral columns, dorsal and lateral, yeah. They get knocked out. And you can get dementia, you can get optic atrophy, so a lot of neurological signs and symptoms. Okay. On investigation, you can see the macrocytic picture, and the neutrophils have hypersegmented nuclei. Because the cells are getting broken down, you'll get raised bilirubin, low B12 and folate, and again you can look for causes. So Schilling test, what am I looking for there? Which condition? Pernicious anemia, yeah. Antibodies against your parietal cells or intrinsic factor, what's that? Pernicious anemia. And TTG, celiac, tissue transglutaminase, antibodies against that, excellent. So, and you can probably think of others as well. How are we going to treat it? Again, you can treat the anemia with a blood transfusion. You can replace your B12 and folate. Okay, so this is a learning point. If you find that someone's folate is low, always check their B12 as well. Because if they have B12 deficiency and a subacute combined degeneration of the cord, and you treat only their folate, you can exacerbate the subacute combined degeneration of the cord and that neurological problem. So always check them for both, and always make sure if they have a low B12 that you're treating that in addition to treating the folate. Does that make sense? Okay, and finally treating the cause. Okay, so we're doing really well. We've covered microcytic, macrocytic. Let's have a look at haemolytic anemias. So I've broken them down into some categories. So there are hereditary causes, basically anything that makes your red blood cells more fragile and more vulnerable. So anything that affects the membrane, anything that affects their metabolism, and anything that affects the hemoglobin. So if you break it down like that, we've got quite a few. Now the learning point on here, this is just one for the examiners. Have you guys heard of glucose 6-phosphate dehydrogenase deficiency? Yeah? And who knows what a fava bean is? No one? Me neither, really. It's like a green bean. Does anyone know what the link is between that?
It exacerbates that.
Yeah. Do you know why?
Because of the glutathione pathway.
Yeah. So basically, this is a condition where you have a lack of this enzyme, and it affects the metabolism in your red blood cells, but it's only if it's exacerbated by certain things. More common things would be things like drugs or oxidative stress. But one thing that the examiners love you to know is fava beans. So if someone eats a load of fava beans and then gets a haemolytic anemia, you can guess what it might be. Okay. So traumatic causes, March haemolytic anemia. Does anyone know who might get that? Have you heard of it before? People that march, so soldiers that trek through the desert, marathon runners, basically that just to impact, you just pound your red blood cells. Prosthetic heart valves that aren't working very well can mash up your red blood cells. Microangiopathic picture, so when you get fibrin strands plugging up your blood vessels, such as in DIC, and we'll have a look at DIC, again they just shred your red blood cells, and malaria can obviously destroy your red blood cells. Immune causes, so if you're producing antibodies to your red blood cells, if you've got a mismatched blood transfusion, hemolytic disease of the newborn. When do you get hemolytic disease of the newborn? Rhesus, yeah. So who's rhesus positive?
The baby.
The baby, yeah. And the mum's rhesus negative, and the mum's already had a baby that was rhesus positive in the past. So that's exposed her. She's produced antibodies, and in the subsequent pregnancy, they can cross. And that's why we now treat mothers who have that. Okay, antibodies, you can get warm antibodies, you can get cold antibodies against your red blood cells that are associated with these conditions. It's quite small print. Certain drugs can cause your body to have an allergic autoimmune reaction against your red blood cells. And this last one, paroxysmal nocturnal hemoglobinuria, basically it's a problem with complement, and complement breaks down your red blood cells. So, on investigation, someone with haemolytic anemia will be anemic, and we've already gone through the symptoms and signs. They'll be jaundiced because they're breaking down their red blood cells and making a lot of bilirubin, and hepatosplenomegaly because their spleen is just breaking down all of their red blood cells. They have a raised MCV because there's a shift, so the more immature red blood cells, which are bigger, come out into the blood. And reticulocytosis or polychromasia, so they're the same things, means your reticulocytes, your early blood cells are in the bloodstream. So what's the normal value of reticulocytes in the blood? It's a tough one. It's less than 2%. So if you get more than that, it suggests a hemolytic picture. Increased unconjugated bilirubin. Decreased haptoglobin. Now, haptoglobin is a protein in the blood that binds broken down fragments of your hemoglobin, so it will be lower if there's more to bind. You can get hemoglobin in your urine and hemosiderin in your urine. That's if it's intravascular hemolysis. So you can get intravascular hemolysis and extravascular. Intravascular is in the blood vessels, extravascular is in the spleen, and often there's an overlap, so you very rarely get just one. Now, what are these tests at the bottom? Coombs tests. What's that testing for? Yeah, it's testing for antibodies. Osmotic fragility tests, when will they use that? Yeah, membrane defects, so they're much more vulnerable and fragile. And hemoglobin electrophoresis, that's for things like sickle cell and your thalassemias. Basically, there's a problem with your hemoglobin. It makes your red blood cells much more fragile and they get broken down more quickly. So we're going to treat the cause, blood transfusion, splenectomy, if your spleen's chewing up all your red blood cells, and there's obviously a lot of genetic counselling involved because there's a lot of hereditary conditions there. So I mentioned sickle cell disease as one of the causes of haemolytic anemia. Sickle cell disease is autosomal recessive. It's a mutation in your globin gene, and you make hemoglobin S. Hemoglobin S sickles, so it forms crystals at stressful conditions such as low pH, low oxygen, infection and dehydration. And the combined effect of sickling in your red blood cell is that your red blood cell becomes more fragile and it's more likely to get chewed up by the spleen. And also your red blood cell becomes stickier and it sticks in the blood vessels. And from just knowing that pathophysiology, you can work out what the symptoms and signs are going to be. So if you get blood cells stuck in your blood vessels in any of these organs, these are the sort of effects that you get. So there's your list of symptoms and pathology associated with sickle cell disease. How are we going to treat it? So learning point, we've said that these stressful conditions will induce sickling, so you just need to reverse them. So low oxygen, give them oxygen. They're dehydrated, give them fluids. Infection, give them antibiotics, and so on. You might also have to give them a blood transfusion. Hydroxyurea, it increases the amount of hemoglobin F, which is important because that obviously doesn't contain the beta globin. People with sickle cell disease, because they infarct their spleens at a very early age, so they autosplenectomize, and so you need to give them prophylaxis against infections and genetic counselling. Okay, so that was the anemias. That's all on your syllabus. Okay, so now we're looking at the malignancies. Myeloma. So malignancy over plasma cells. How does it present? So you can break it up. Basically, your plasma cells are within the bones. They cause lytic lesions of the bones. So people will have bone pain. They'll have pathological fractures. What's a pathological fracture? So it's a fracture that occurs on minimal trauma. Minimal trauma. And because you're breaking down your bone, your calcium levels will go up. So how would high calcium present? Yeah, that's really good. I heard you guys groaning that, so that's great. Paraprotein. So what's a paraprotein?
Single immunoglobulin.
Yes, a monoclonal immunoglobulin. Yeah, that's great. So you get just one, you get an excess of one type of your immunoglobulin. And that causes immunoparesis, so you'll become immunosuppressed with it because you just can't make enough of your other types. And so you're prone to infection. Your light chains from this excess immunoglobulin can clog up your kidneys and you'll get renal failure. And you can clog up your blood vessels and you get hyperviscosity. How does hyperviscosity, how might that present? Yeah, clots. So clots, which can be, for example, in the brain, you can get headaches, you can get strokes, you can get clots in your eyes, visual disturbances. And amyloidosis. Who knows what amyloidosis is?
Liver degradation?
Not, well, it can be caused by different things. It's an excess of protein. Lots of different proteins can cause it. And you get protein deposited all around the body, in lots of different organs. In your tongue, you can get a big tongue. At your wrist, you can get nerve palsies like carpal tunnel syndrome. And it's, in this case, it's due to all the excess light chains, so all that excess protein gets deposited around the body. Okay, so on investigation, with your myeloma, you'll get a normochromic Haemolytic Anaemia, which is the anemia of chronic disease. You get raised CRP or ESR. I've said because of the bone destruction, your calcium will go up, but here's a learning point: your alk phos will be normal. So I've said that. What other bony condition can give you a raised calcium, but instead of raised alk phos, that you might want to distinguish the two? Paget's, yeah, excellent. So they're the two you can sort of get a bit mixed up on multiple choice questions. So myeloma, your alk phos will be normal. Serum electrophoresis, you're looking for that spike of your monoclonal immunoglobulin. It's called the paraprotein or the M band. It all means the same things. Benzostone proteins in your urine. What's a Benzostone protein? Light chain, yeah, excellent. You can have a look inside the bone marrow. It's stuffed full of plasma cells. And you can do some x-rays and you'll see the classic lytic lesions. Okay. How are you going to treat it? Chemotherapy for the myeloma. And obviously I mentioned all those complications like high calcium, the bone fractures, the renal failure. You've got to remember all of those. They'll be really important to treat. So that was myeloma. On to lymphoma. So malignancy of your lymphoid cells. Okay. Basically, I'm going to talk about the lymphomas and the leukemias. They're basically one and the same. Lymphomas tend to affect more your lymph nodes, but they can spill out into your blood and your bone marrow. And leukemia is just the other way around. Tends to affect the white blood cells in your bone marrow and blood, but can spill over into your lymph nodes. You've got Hodgkin's lymphoma and non-Hodgkin's lymphoma. The classification is really quite complex and it's beyond the scope of your syllabus. Just learning point, Hodgkin's lymphoma is associated with Reed-Sternberg cells, which look like what? Owls. They look like owls, yeah. And you can get your lymph nodes swelling, becomes painful after you've drunk some alcohol. So, classically. Okay, how will lymphoma present? So masses, lymphadenopathy can spread into your liver and spleen, hepatosplenomegaly. In addition, you get these B symptoms, so systemically unwell. And finally, you can get bone marrow failure. We're going to to investigate, we're going to have a look in the lymph nodes, in the bone marrow, and do a CT and a PET scan to see how far the lymphoma is spread. Who's heard of the Ann Arbor staging classification? Yeah, one or two of you. I don't know how relevant it is. Basically, there's 4 stages. Stage 1 is one lymph node, one group of lymph nodes. Stage 2 is lymph nodes on the same side of the diaphragm. Stage 3 is on both sides of the diaphragm. And stage 4, you've got spread outside of your lymph nodes. Treatment, chemotherapy or radiotherapy. Leukemias, I've said they're just the other end of the spectrum to lymphomas. They're very similar. You divide them into acute and chronic. So in chronic leukemia, it's basically the cells are relatively well differentiated, and the problem is that they're just not apoptosing. With acute leukemias, there's a problem, they're not differentiating and they're not apoptosing, so you've got these really immature cells that won't die. And you can get transformation, so you can see to get from a chronic to an acute leukemia, you need a mutation which knocks off your differentiation, because both of them lack the apoptosis. And you can divide them into those that affect the lymphoid or the myeloid lineages. How do they present? Really similar to your lymphomas, bone marrow failure, systemic symptoms. We'll investigate in a very similar way and treat again in a very similar way. Okay, so that was the malignancies. So on to clotting disorders. Haemophilia. So we've got haemophilia A, B, and C, which affect clotting factors 8, 9, and 11. They're all X-linked recessive, which means what? Tends to be men that are affected, yeah. And which famous person has this in their family? Who is that? Queen Victoria. Very good. How might they present? Learning points, joint deformities. They bleed into their joints, which hemarthrosis damages the joints. And if this occurs again and again, they'll get joint deformities. They can bleed elsewhere, such as in their urine, and have excessive bleeding after surgery and trauma. How do we treat them? We can actually transfuse them with artificial factors now. And obviously give them lifestyle advice. So you wouldn't give an intramuscular injection to someone with haemophilia because it will bleed within the muscle. Just a side note about the factor transfusions, it's really sad. Back in the 80s, a lot of haemophiliacs contracted HIV and hepatitis as a result of their transfusions. Obviously they're now much safer.
Is any of the haemophilias, do they differ in severity?
They probably do. I'm not aware which is the more severe of the two, but they probably do, you're right. Yeah, because obviously they knock out different parts of the pathway. Okay, so from both philias, conditions that mean your blood is more likely to clot, and there's a whole long list, and basically you can look at your clotting cascade and work out which proteins you need to mutate to increase your chance of clotting. At the very bottom I've got antiphospholipid syndrome. It's got a triad that you need to know about. these are people that tend to get venous clots, arterial clots, and miscarriages. So that's the classic triad. Why might you suspect someone's got thrombophilia? If they've got a family history of clotting, if they're getting clots at a very young age, if they're getting recurrent clots, or if they're getting clots in an unusual site. Who can name an unusual site that you wouldn't really expect to find a blood clot? Anyone?
Hand.
Yeah, your hand's quite unusual, yeah. They